All right, welcome everyone to today's webinar. We are super excited to be here sharing some of the work that we've been doing in the TRANSnetwork, which is the Transgender Health Research and Advocacy Network in the South. Today's webinar is called Supporting Trans and Non-Binary People's Resilience in Healthcare Settings, and I'm thrilled to have some of the most awesome thought leaders in trans and non-binary health that are going to be sharing their expertise and experiences with you today. My name is Annalise Singh, and my pronouns are she, her, hers, and they, them, their. I identify as a genderqueer femme, mixed race person, and I serve as Associate Dean of Diversity, Equity, Inclusion in the College of Education at the University of Georgia. I also work with TRANSnetwork, which is supported by a PCORI grant, Patient-Centered Outcomes Research Institute. So we're very grateful for their support. I wanted to start introducing you to some of the wonderful webinar panelists that we have today. Ms. Tori Cooper, her pronouns are she, her, hers, most recently served as Trans Health Coordinator for a local HIV and advocacy agency where she headed the Real T program. Real T stands for Reaching, Empowering, and Advocating in the Lives of Trans People. The cornerstone of this program was the Real T Empowerment Group, which aimed to empower those living the quote-unquote trans experience to live more productive lives through education and advocacy. I can tell you that not only does Tori hold a BA in Human Services and is pursuing her master's in public health, she's a gifted speaker and educator. She's been a thought leader for so many people in healthcare and education and has tirelessly worked in Atlanta, nationally and internationally, providing her expertise on African American, trans, and HIV communities. She strongly believes that every opportunity is another chance to learn and to educate others. So thank you so much, Tori, for being with us. Next, we have Evelyn Olansky. Her pronouns are she, her, and hers. She is a public health researcher and a member of the trans community. She received her master's degree in public health in the spring of 2015. Her academic background includes psychology, linguistics, and anthropology, with a public health specialization in epidemiology. Her thesis research examined differences in risk behaviors and geographic attributes of social networks dependent on their location in or out of zones of high HIV endemicity. Her most recent work focuses on the trans community, serving as a lead interviewer of a study on stigma, trauma, and stress in trans women, and as an ethnographer in ongoing formative research on the inclusion of trans communities in widespread HIV behavioral surveillance instruments. Next, I have right next to me Becca Estevez. Her pronouns are she, her, and hers. I get to work with her all the time. It's a joy. She's a current PhD student in counseling psychology here at the University of Georgia. She previously completed her master's here in counseling, also at UGA, and she studies resilience at the intersections of identity, especially with best counseling practices for the LGBTQ plus community and with trans folks of color. She is the co-founder of UGA's College of Education Trans-Affirming Practices Task Group and provides individual counseling services for a wide range of presenting concerns. She is also a project coordinator of Project Affirm, an NIH-sponsored grant exploring the identity development of resilience in trans and non-binary individuals. I know that was a lot of intro, but I think, we always want to know who is presenting to us when we are on webinars, and we thank the audience greatly for being here with us today. One thing I do want you to know as we get started is that I have questions and answers that we are welcoming throughout the webinar today. So you can hop on the Q&A button at the bottom of your screen and you can type in those questions. I'll also be running a few polls as we get started. So Evelyn is going to be advancing us through our slides, and let's go to the next one. So as we get started, I did all the intros. Here are these amazing, fabulous people that we'll be learning with today. And as we go to the next slide, you will also see that here are our learning objectives. So basically, we're talking about barriers that trans and non-binary, or we shorten that to TNB people, experience. We're talking about some intersecting issues of oppression and how that affects healthcare. We're also looking at specific factors of resilience, and we'll start off with kind of talking about resilience and what that is, and the specific actions that you as a provider, you as a community member can take to facilitate resilience, considering the extensiveness of trans prejudice and other oppressions in healthcare settings. So as we move forward, the other thing we wanted to mention about today that is so important on the next slide is that today is the Trans Day of Remembrance. And, you know, that is such an important day for where many years now we've read the names of people who have lost their lives, who've been murdered, maimed, experienced brutal ends to their lives, or completed suicide due to multiple oppressions. We've also seen this very important day, which is affectionately called TDOR, as adding another R, which is, yes, let's call the names, but let's also celebrate the living and the allies and the co-conspirators and accomplices who are building a better world where trans people don't only have to be resilient. So we really wanted to honor that. We are a part of TDOR today and feel very grateful to be here with you. And so as we move to the next slide, one of the things we need to really think about is, what is resilience, right? If you look at literature around resilience, or if you think about resilience yourself, often we think about resilience as this ability to bounce back. Like, I've had a bad day, I didn't get the right coffee when I was at the coffee shop, or like, wow, I'm feeling a little depressed. It's like that thing that you're feeling throughout the day that's kind of hard. It might be, you know, not just that you got the wrong coffee, or that, you know, I'm feeling a little depressed today, but it also might be other significant adversity. So adversity can really range when we're talking about resilience, but many researchers, mostly white and Western kind of conceptions of resilience, really look at resilience as this ability to bounce back individually. Now, what has happened is, we've studied resilience over many decades, is that many researchers have called for a more collective understanding of resilience. And even if you look at the individual conceptions of resilience, there are aspects of interpersonal relationships and social support that's always been there. And I think, you know, some of this leads us to talking about, I like to put it in quotes, the minority stress model, right? You know, kind of looking at, yes, trans people, for example, for non-binary people, for example, experience resilience, but they also experience minority stress that they have to be resilient to. And so that brings us a question when we think about trans and non-binary resilience, like, you can bounce back to like an average level of functioning, but what if cisgenderism, racism, and other oppressions aren't going away? And so if those oppressions are consistent, they're persistent, they're embedded in institutional structures, resilience becomes a key construct to look at. Now, some of the criticism of resilience research is actually really important to talk about. If we only study resilience, then are we furthering this idea that we're not really looking at the people that are causing, which includes all of us in healthcare, right? Kind of causing the conditions, contributing to the conditions that require that trans and non-binary people be resilient to oppression. So one of the things we wanted to say at the start of today is that we understand this critique, we welcome it, and we definitely are looking at trans and non-binary resilience to oppression. So what is the oppression that sits on top of trans and non-binary's everyday resilience? And how do we support people through that and overcoming oppression in healthcare settings, not as just an individual act, but as a community experience and community advocacy that we can all participate in, that is aimed at liberation. And so resilience is not just the bouncing back we're looking at, but what is the ultimate liberation place that we want to see in healthcare settings. And we hope we have a good dialogue with you all about that today. So as we move to the next slide, we know now that we're not talking about everyday resilience. We're talking about the everyday resilience that trans and non-binary people develop to navigate oppression. And so I'm noticing on this first slide, it's missing a word, but some of the early studies that I personally did with trans and non-binary resilience to oppression, to trans stigma, really talked about people evolving a definition of their self. What were the words, the pronouns, the names, the concepts, just the intersections of language that were so important to trans and non-binary people as they evolved a sense of who they were. Having ownership of that was a huge resilience strategy. The other thing was embracing their self-worth in spite of oppression and because of oppression. And that led to this next domain of resilience we found, which is being aware of oppression. Now that might seem like a no-brainer, but it was an actual very strategic resilience strategy of being able to say, actually, this isn't about me. If I embrace my self-worth, if I know who I am, this is about a system that is not built for me, and that is not my problem, but it's something I've got to navigate. And the next two resilience strategies were about having a connection with a supportive community. Again, there's that interpersonal component of resilience, and then cultivating hope for the future. This was not a la la la, let's just be hopeful. This was a very strategic, intentional, if the world is set up to try to trick me into I shouldn't be here or I don't have this self-worth, I am strategically and intentionally planning my hope for the future because I deserve to be here, I want to be here, and my ancestors fought for me to be here. As we move to the next slide, we wanted to also mention that, resilience has been looked at intersectionally, and not just with race and ethnicity, around age, around disability, around class. One of the things we wanted to highlight today, especially as we're talking about healthcare settings, is that people of color who are trans and non-binary have their own resilience intersections that we need to consider. So as they're entering healthcare settings, depending on how much people have evolved their sense of self, their pride as a trans or non-binary person, as a person of color, those things can help buffer experiences of oppression, but also the things they have learned in terms of navigating family relationships, both negative and positive. Those navigations can help them navigate other systems of oppression with racism and anti-trans bias. This is why we care about this today in today's webinar, is this next resilience strategy, accessing healthcare and financial resources. People of color who are trans and non-binary said as soon as they hit the door of our office, actually before they ever accessed healthcare, they were thinking about how to advocate for themselves. They were talking to community members to find the tricks and the trades of dealing with messed up healthcare providers, right? And they were planful, right? That came back to the connection with community, but also activism for people who were coming behind them, experiencing the same things. So what I'm going to do now is we're going to move to the next slide, and Becca's going to talk about the role of mental health care providers in supporting resilience.
Absolutely. Thank you, Annalise, and thank you for having me. This panel is full of folks that I look up to and leaders, and I'm just feel very privileged to be here. So I know that not everyone on this webinar today may be mental health care providers. So I do want to say, even though that is kind of the focus of my section, I believe that a lot of the information that I'm going to be talking about today can be used in other settings as well. So on this first slide, I just want to highlight for those of us on here who are in a mental health care settings, all of our ethics codes call for us to infuse social justice and advocacy into our work, our teaching, and our research. Why is that? Well, a lot of times what we see in mental health care practice is we can get super focused on an individual dyadic relationship, when what we know from the research is that if we don't change the client's environment, if we don't attend to some of the things that Annalise was just talking about, these systems of oppression that are happening in our clients' lives, we can't really fully help our clients. And the literature shows that we have, as mental health care professionals, from the master's level all the way up to the doctoral level, we have the research skills and the knowledge and the awareness to where we can really make a difference in our society. So kind of a call for us to do this work. And then can you hit it? Thank you. I just want to briefly go over some early experiences in mental health care, because I think it's important to know that your clients who are coming in to see you know this history, have probably experienced some of these things. So very early counseling practices included years of psychoanalysis, very long-term assessments in order to see if someone was worthy enough or past enough to get access to healthcare. There were forced dissolution of marriages in order to prove that you were indeed the gender that you knew yourself to be, and really a lack of awareness about non-binary identities, a very binary focus. We know that that trans and non-binary identities are very much pathologized, unfortunately, within training programs, and also within experiences that folks are having. For example, I put up on here in the DSM-5, we do have gender dysphoria. The folks who put in gender dysphoria have an escape clause, which is clause B, saying that you can only be diagnosed with this if you experience distress. And then we know in the ICD-11 that it was recently, I believe, as soon as 2018, it was moved out of mental health disorders and classified as a sexual health condition. And so these are things, ways that the healthcare community is trying to grapple with some of these issues. But I pulled a quote that I know I'm reading off of my notes, but I want to share the voice of some of the community members regarding this. So trans activist Nua Fuentes said this in response to the ICD change. Being trans is still included in the disease manual through words like gender incongruence and experienced gender, which would have us think that there is a real identity that would be cisgender or heterosexual and a secondary trans identity. We don't want this hierarchy. And so I think I just want to bring that narrative from the community and kind of have a call for all of us who are practitioners to be thinking about how we can better align with community. Evelyn, next slide. I know this slide is very wordy, and apologies, something I'm working on, but I did go into the literature and I pulled just some qualitative experiences of that folks within the trans and non-binary community have reported, both within a more physical healthcare settings as well as mental health care settings. So the McCullough et al. 2017 article there at the top, I'll just highlight some of them. This is in regards to therapy experiences for trans and non-binary folks. So just a general lack of knowledge about trans and non-binary identities, experiences from trans and non-binary clients about interpersonal bias, refusal to use correct names and pronouns, visual discomfort happening between the therapist and their client, and insensitivity to intersectionality, and assumptions that the client is coming in and everything they're talking about is because they're trans or non-binary. And then the Robertson-Vance 2014 article is specifically talking about, it's a qualitative piece talking about experiences of trans and non-binary patients within the healthcare, physical healthcare setting. So things like a binary identification system and electronic medical records, issues with health insurance and barriers to care. We know within the ACA, there should be no discrimination that should be happening under ACA. However, we know that insurance companies have all kinds of loopholes and ways around that, and that it's a very significant barrier for trans and non-binary patients. Overlooking necessary care and providing insensitive care for varying things. I asked permission for my husband, who is a Latinx trans man, if I could share this, and I'm sharing with his permission, that as a trans man, he has experienced a lot of barriers and a lot of just weirdness was his word of talking about it when he goes to get a gynecological exam. And so that is also something that's reflected in the literature as well and can be a very serious barrier to care, as we know. Economic disparities, Annalise talked about, directly impact folks seeking care. And again, the same thing, a lack of training, just a global lack of knowledge about trans and non-binary identities and specific needs happening both within the physical and the mental health care settings. Okay, Evelyn, next slide. So trans-affirming counseling, this is the definition from Annalise and Laura Dickey. And I believe, even though it's talking about counseling, I believe that it is something that can be translated to trans-affirming practice, no matter whether you're in the counseling field or in any other healthcare setting. So it is a practice that is culturally relevant for clients and their multiple social identities. It addresses the influence of social inequities on the lives of clients. It enhances client resilience and coping, and it works to reduce systemic barriers to mental and physical health, leveraging client strengths. So I would absolutely, in my own practice as a trainee in psychology, I try to reflect on this definition, reflect on where I am and where I am not living up to this definition, and how I can better educate myself and better live up to that definition. So maybe a call for other folks to do as well. Evelyn, next slide. So we would like to just put forth some affirming trans narratives. Again, I believe that this is applicable to both mental health care professionals as well as physical health care professionals. So affirming trans narratives that you can adopt for yourself. Trans people know who they are, period. Trans people are in charge of their own mental and physical health. We know that there are gatekeeping issues, which I'll talk a little bit more specifically about in a few slides. And one of the things that is something that we can do as mental health care professionals is move towards an informed consent model, which I will also get into a little bit more. There is no one correct way to be trans. And trans people do have healthy and loving relationships. So I would encourage everyone to kind of think about these narratives, reflect on them, and see if they make sense for you, and see if you can adopt them into your practice and what that might look like and how that might shift your practice. So making your office more trans-affirming. This may seem like a very small thing, but it is a very big thing. Again, I can share with my husband's permission, he looks for these kinds of things when he goes into both mental and physical health settings, and kind of bases whether or not he goes or returns to a therapist, for example, on this. So it may seem small, but it's very big. So think about, and maybe some reflection time, but what in your office and waiting room actually signals to clients that you're affirming? What needs to be changed on, like, your marketing materials, like your social media, your website, your intake paperwork, your assessment documents, that will actually be a signal, I'm potentially safe. And I put the word potentially there on purpose because, as we know, clients don't have to trust us and have no reason to trust us. We need to show that we are trustworthy. And this is one small step that we can take to say, hey, potentially I'm someone that you can be safe with. Very quickly on intake paperwork, some suggestions would be, to have a space where people can write in their gender identity. If you do have to, for EMRs, for example, have check marks, trying to be as inclusive as possible with the options that you have, is some suggestions. And then another thing, both for, really healthcare providers in any setting, where are opportunities for you to advocate for your clients within your everyday practice? So again, some things to reflect on. Next slide. Yeah. Very, very, very briefly, I just want to touch on this for the mental health clinicians in the room. A little bit about referral letters. You can see on the screen what the requirements are based on WPATH. However, what I really want to focus on is the latter part, which is collaborate, educate, and advocate, right? So we want to move more towards informed consent models. What's informed consent? We do it every day and other kinds of practices. You go to get a flu shot. I just got a flu shot, right? And I didn't have to go get letters or anything like that. Like, they literally said, hey, here are some things that you might experience. Here are the benefits of getting it. You cool with that? Great. And I got my shot. So that's something that we want to start moving towards. And I believe the folks on this webinar would agree to really, again, trans people know themselves, and trans people are in charge of their own healthcare. And this is a way we can start to reduce the gatekeeping that occurs within the mental health profession. I do want to point out this amazing resource, because we know finances can be a big barrier. It is the gallup.org, the Gender Affirming Letter Access Project. And it's where you can go and be part of this project. And you can sign up to do 1 to 2, I believe, pro bono letters for clients. So it's an amazing resource. If you are a licensed clinician, please definitely look into that as a way to advocate.
Yeah, thanks, Becca. And I'll just say, I just signed up about a month ago. It's so easy when you go to their website, and every month you just promise to do a certain amount of pro bono letters. So thank you so much for Becca for sharing about that. That's awesome.
Okay, next slide. All right, Evelyn, your turn.
Thank you, Becca. What an incredibly comprehensive setup for all of this. I really, I didn't see your slide about Gallup before, but if that had existed about 6 years ago, it would have saved me about 1.5 years worth of time in therapy.
Wow.
So,
wow.
I like to say that every trans and non-binary patient has, in addition to the medical history that you get to see, they also have an unwritten medical history of all of the times that they've attempted to engage in healthcare and how those attempts to engage have gone for them. As Becca laid out very thoroughly, the list of things that can go wrong is very large, and it ranges from things that are, as Annalise, the metaphor she used earlier, ordering coffee and then getting the wrong coffee in the morning. That's sort of on the low end of how things can go wrong. And on the high end, it's complete invalidation of your identity. It's important to know that only your patient can provide information about how things have gone wrong for them in the past. That usually is not included on the medical history you may receive if they're referred to you or just from the intake process. It's very, I think the first step is often missed because it starts even before the patient arrives at your door, which is to say, acknowledging that they have had prior experiences and acknowledging that in some cases the intensity of those experiences may interfere with your ability to build rapport and create a functioning provider-patient relationship. If they have experienced persistently poor treatment or even a single strongly negative encounter, they may rightly anticipate the same from you until they know a little bit more about you, until they know what your values are relative to an identity like mine. So it's really, I think I call this step 0 because it's so foundational. You have to understand that for trans and non-binary patients, the stakes are often higher than you could even imagine. The consequences of a bad healthcare encounter can be denial of access to appropriate treatment, humiliation, stigmatization, even barriers to obtaining legal rights. And once you've experienced that, that is an anticipation that is so great, it can taint nearly every healthcare encounter that you have going forward from that moment, whether it's related to gender or not. Medical mistrust kind of gets on everything. It inverts the traditional provider and patient dynamic, and it interferes with implicit trust and instead creates a situation, as Becca described, where trust needs to be earned. So Becca also mentioned self-definition, and Annalise as well. Self-definition is central to the lives of many trans people, and that is in many cases because we were not given definitions in the traditional ways through sources of conventional wisdom in school, in you name it, in media. We have had to create ourselves for lack of images of people like us. And that is a method of survival for many people. As a result of the importance and centrality of self-definition, when it comes up against medical authority, and in the worst cases, when medical authority rejects a trans or non-binary person's self-definition, you might be tempted to think that medical authority wins in this case. It's a tempting notion to think, well, who can argue with medical authority? But the truth of the matter is, when you reject something that is so central to how a person sees themselves and so central to their experiences and their very survival before they arrived in your office, when you reject that, you have undermined your authority to that person. A credible clinician has to see me for who I am. If they cannot see that I am a transgender woman, if I tell them that and they still won't affirm or acknowledge that fact to me, they might as well be telling me that the sky is rainbow polka dots. You would not trust the medical opinion of someone whose vision of reality is so divergent from your own. So how to address this? I think we often treat new clients and new healthcare encounters like it's a clean slate. And I think that's particularly a mistake for trans and non-binary patients. It may be useful for you to probe or investigate about what their prior experiences in healthcare have been. Me, for instance, might just tell you without you asking, and other folks, you may just need to acknowledge that there's some sort of connection that's lacking, or they maybe don't seem to fully trust you. And in those sorts of cases, I recommend you try to understand what their prior experiences have been. And that's not to say that you need to co-sign on somebody's malpractice suit or even to validate their thoughts or opinions about medical recommendations that have been given to them. But what's most important is that you recognize the tone of the experiences that they are reporting to you, and that you can report that tone back to them in a way that affirms that the experience was a negative one. I've seen it so many times in my own healthcare experiences. I've heard so many stories about attempting to relate these difficult experiences and then having those experiences sort of repeated back in a very clinical tone, with missing the important part, which is this was an experience potentially bad enough to create significant medical mistrust for the patient. Being able to recognize that, being able to articulate what your patient has gone through back to them, is the best way to initially and very quickly demonstrate your awareness of their issues and your empathy towards those past problems. And that is the best way to differentiate yourself from the kind of healthcare they've received in the past and from the kind of clinicians that they may have struggled with. It can be easy to take it personally. This is, in some cases, this is someone that you've not met, or maybe it's a patient you've seen a few times, and it feels like it's an attitude directed towards you. And I urge you to discard that thought. It is, experience can stick with you. It is not about you, it's not a critique of your profession or you as a clinician when a patient is reporting their problems in the past with healthcare. It is an opportunity, it's an invitation for you to be the solution to that problem, not an indictment of you or people like you. Making trans and non-binary priorities your priorities is the next most important thing. Again, this is another experience I've had on a number of occasions, unfortunately, where I wanted a certain sort of healthcare. I wanted my hormone treatment, and I was neglecting my other health needs at that time because, to me, the most acute health need in my life, the most acute condition of all, was my gender dysphoria, my experiences of discrimination related to not having legal and social recognition as a woman. Nothing else mattered to me, and while that may be, some of that may be related to nihilism and depression and various things, it is a recurring, it's a recurring thing among trans and non-binary people that they regard this sort of treatment as more important, more urgent than many of their providers are willing to see it. To connect a little bit to my research background, a little less to my personal experience seeking healthcare, we've actually seen this in the research. There's vanishingly little trans research out there, but among that which exists, they've found that if trans and non-binary people are receiving the gender-related health care needs that they want, they will stay in care for other reasons. They will return for well visits, or they, in some cases, some studies indicate they're more likely to stay adherent to antiretrovirals or PrEP or other medications that require adherence. So it's well documented. It's not simply an anecdote you have to take my word for. It is a priority. And if you do not see it as a priority, then you will probably not be that person's provider for very long. Becca got into this pretty thoroughly, but you need to serve your trans and non-binary clients proactively, which is to say, do not simply do things because you have been asked by a trans and non-binary client. Attempt to find things that they may ask you to do, ways that they may seek accommodation from you before they have asked. And this will require you to examine your standard practices through the eyes of a trans and non-binary person. And Becca did a great job covering that. I want to suggest, push it a little bit further. It can be hard to look at something through someone else's eyes. So if it's possible, if it's within the policies of your organization or your clinic or what have you, I recommend you actually you pay a trans or non-binary person to come into your clinic and assess it, tell you how it looks to them, because if you are not looking through the eyes of a trans and non-binary person, then you are very likely to miss things. Moving from the information you get when you examine your standard practices, look first for feasible ways to accommodate your clients better. And by feasible, I mean things where you don't have to run it up the chain, or you don't need to seek some sort of approval. Say there's a document or a form that is completely internal to your office. No one has oversight. You can change it. Make those changes without someone twisting your arm to do it. And then beyond that, the advanced practice here is identify institutional barriers. And that's sort of the other side of what I meant by feasible. Some things you will not have the power to just open a document, make a few changes, save it, and print. There are things that are outside of your control, but it's important that you learn to identify those things and further learn what can be done. And in some cases, it's the sort of indirect action that many of us are forced to resort to in times of or trying political times. It may be a matter of calling a representative. It may not be the sort of direct change that you are maybe looking for, or the sort of direct change you can do on site, but every bit is important, and you're just as important as participating in that, your awareness of it, knowing the size and scope and breadth of these institutional barriers will help you be aware of the oppression that your clients have no choice but to be aware of, essentially. And I know I said before, you should try not to take it personally, but maybe you should take it personally. And by that, I don't mean get angry at your trans and non-binary patients when they present difficult information to you. I mean redirect entirely from the trans and non-binary people providing stories of poor health care, because they are only the messenger. You should think about taking it personally when you learn that there are incompetent providers elsewhere in your field, in your city, and the providing service so poor that it is undermining your medical authority and your trustworthiness as a clinician. You should take that personally. You should take it personally when the persisting legality of discrimination against trans and non-binary people leaves your patients unsure if treatment will be humane because it is legal to provide inhumane treatment to trans and non-binary people. Take that personally. Make it your problem that economic and legal inequality are concerns much larger in the minds of many trans and non-binary people than whether they've gotten their flu shot. Once these become not trans problems you are aware of, but problems that you are seeking to solve every bit as much as we are, then really there's nothing to it. If that is true of you, then there's no magic recipe of how do I make myself seem trustworthy. This is it. This is being in the same boat, more or less, is the best route to making yourself a trustworthy provider. And that's my section. Tori, we have you on the line?
Yes, good afternoon, everyone. So I'm having some internet issues right now, so hopefully this will stay in place for the next 15 minutes at least. All right, so this is just a small breakdown of what we're going to talk about in the next 15 minutes. We're going to talk a little bit about trans communities, some anecdotes and stories around community engagement, which is really an empowerment tool to help to ensure that folks are getting the best care that they need. I'm going to give you a great example of some partnerships with state health departments, or with one specific health department that is making a huge difference in health outcomes for trans and gender nonconforming folks. And this model really can be used in any other community. We're going to explain the importance of community engagement as well, and make some recommendations for strengthening community engagement. And the next few slides are a little colorful, but I color coordinated the slides to go along with the graph. So historically, trans women have actually been invisible in healthcare settings, and that's really, really a problem. Because if you are not visible, if providers can't see you, then that means they're not addressing your needs. Next slide. Trans men, they are like these magical specters to many healthcare providers. And that's important to understand, because as trans men are continually involving themselves in the conversation, we're seeing that there are a lot of unmet healthcare needs. Next slide. The thing is, we're beginning to work together. Healthcare providers may not be able to see us, but we can see each other. Next slide. We're recently including gender nonconforming or non-binary folks into the conversation as well. And so one of the things that we're also realizing is that there's strength in numbers. Hold on, I'm not reading quite that fast. So so we're bringing more folks into the conversation, because what we're finding is there are a lot of folks, and Evelyn and Becca both have mentioned, there are a lot of folks who have differing or varying gender identities, but often have many of the same healthcare needs, and that's going to be really, really important. Next slide. So one of the first things I like to point out, and I'm probably the only presenter that is presenting with a little attitude today, is pronouns are not preferred. And it's going to be important moving forward that as providers we understand that's a simple change, something that Evelyn just pointed out in one of her last slides. That's something that we can change on all of our forms. My pronouns are not preferred. So if you can change your forms to indicate, rather than preferred gender, current gender, rather than preferred pronouns, pronouns, period. Those are ways that you help build trust and empower people to help you to help themselves. Next slide. So with greater visibility brings greater responsibility. And this is just a little historical information. There are a lot of folks who believe trans is new. Well, these are some small instances that have been very, very insignificant in the historical context and greater historical context, but for the history of trans and gender nonconforming folks, this is really, really important information that a lot of us really just are not aware of. So what we're seeing is Karl M. Bayer, a German doctor. He was one of the first people to have what we would now call an F to M surgery in 1906, and he had his birth certificate actually changed. That's almost 100 years ago. Dr. Magnus Hirschfeld in 1919. He created the Institute of Sex Research. It was a transgender clinic that operated in 1930. Really, really important. One of my personal icons is Marsha P. and Norman Johnson and Sylvia Rivera. They started the gay rights movements at Stonewall in 1969, so 50 years and about 5 or 6 months ago. It's also important to understand that in 1970, Marsha P. Johnson and Sylvia Rivera also used money that they earned from prostitution to create what was known as the Star House. STAR stands for Street Transvestite Action Revolutionaries. And the Star House was an apartment that they had turned into a refuge. They had turned it into living facilities for homeless folks who we would now call trans and non-binary folks. And that was in 1970. And yet still, in 2019, we have healthcare providers who are saying, well, we don't know how to house trans folks, or we don't know where to put non-binary folks. Well, the truth is, we figured out solutions to this problem 49, almost 50 years ago. So allow us to help to create solutions that are going to be lasting now in the 21st century. Raquel Welch in 1970 starred in a movie by the name of Myra Breckinridge. It's now a cult classic. You can order copies of it on Amazon. The reason why this is so important is because it's the first time that the words trans and gender were used together, and this is the first time there was a positive representation of us in media. This was a major film release in 1970. I think it's also important to note that Raquel Welch at the time was considered the most beautiful woman in the world. So look at the irony of the woman, the cis woman, who was considered the most beautiful woman in the world, playing a character who is transgender in 1979. I think that's a historical recognition, something that all of us need to know. And I encourage us as providers to make sure that we're empowering our clients and understanding that trans isn't new. Next slide. Health department partnerships and community engagement. This is a lot of words, so I'm not going to read through all of them, but I'll read some of the highlights. So the San Francisco Health Department established Gender Health San Francisco to provide access to gender-affirming surgeries, education, and preparation services to eligible uninsured transgender adult residents. That's really, really important because we have a time in administration where there are continual assaults, really, on the Affordable Care Act, what's also known as Obamacare. That's a federal program that allows folks who don't have private insurance to buy into private insurance, to buy into the insurance system. Currently, the San Francisco Department of Public Health also provides a range of health services to transgender residents, including primary care, prevention, behavioral health, hormone therapy, specialty, and inpatient care. So what they're doing is San Francisco is providing full service care, things that are not just addressing one of the issues that are impacting their transgender clients. What they're doing is they're approaching primary care. And primary care, for many of us, or especially folks who perhaps didn't grow up with private insurance, there is no such thing as preventative health care. Your doctor was the emergency room doctor. You got your physicals at high school, in school at the beginning of the year, perhaps. So there wasn't, if you had a cough, you'd have to be sick before you went to a doctor. There was no such thing as going to a doctor to get preventative care. So it's great that they listen to the folks in the community to determine, well, hey, how about if we add some preventative care, perhaps we can avoid some of the unfortunate health consequences that come without having traditional health care. So this initiative, which is really, really, I think, the most important part, it was born out of the incredible work of community advocates. Community advocates, and those community advocates were folks who are in the trans and non-binary community. Next slide, please. So there was a lot of input from the TG community in San Francisco. The Board of Supervisors adopted Resolution 28812 in July 12th, encouraging the department to ensure the provision of medically necessary and gender-affirming transition-related care. This is important because, as Evelyn pointed out, and as Becca hinted at as well, for trans folks and perhaps some gender non-binary folks or any folks who are using hormonal therapy, it is important to understand that for some of us, gender-affirming therapy is going to come before anything else. If you happen to be a trans person who's living with an HIV diagnosis and you take hormonal therapy, it is not uncommon for folks to say, I need my hormones before I can think of anything else. Because hormone therapy validates who people are, even when the public may not be able to see that. And I think that's really, really important. So in addition, in November of 2012, the San Francisco Health Commission, they approved the following. And these are three really, really important bullets that we can take back into our own respective communities. They developed new programming, the Gender Health San Francisco, to manage gender-affirming surgery and access to uneligible insured trans folks that we heard already and non-binary folks. But they also use gender identity disorder, which is also called, now referred to as gender dysphoria, as a clinical indication for surgical purposes. Now, this particular point for some folks in recent years could be considered a little, what's the word? Some people may have a little problem with that, but it's with the term gender dysphoria. But it is important to understand that this is a medical diagnosis. And for many of us who have been given a diagnosis of gender dysphoria, it has allowed us to have gender-affirming therapies covered by medical insurance. It doesn't mean that a person is crazy. It is simply a diagnosis. It's a medical term that allows for certain coding measures. And for those of you who perhaps work with insurance companies or work with behind the scenes, it's important to understand why that is so important. Even if a trans person is not aware of that, that's a discussion that perhaps you should have. One of the third bullets I like to mention is they've removed transgender surgery from the list of excluded services under the Healthy San Francisco program. Transgender-related surgeries are life-changing. There are some of us who may never choose to have any types of surgeries, but for those who do, these surgeries can be life-changing. Next slide. Here are some very, very simple recommendations. This is certainly not a comprehensive list, but it is important to understand. Healthcare providers need to empower their TGNB communities across the country to prioritize solutions that work best for themselves. So this could be a little confusing, but what I recommend, what I recommend is that engage in community assessments. Community assessments are ways that you can talk directly to the people who are going to benefit most from the services that you offer. Housing is going to be a huge priority for trans people who are living in the South. But perhaps in places like New York and Chicago, housing may not be in their top 10 things of concerns. So it's important to understand what your community needs wherever it is that you live. Create positions specifically for transgender engagement. So transgender folks, we don't just do testing, but it's important to understand there's some of us who would be great testers. There's some of us who will be incredibly powerful in counseling positions, but there are also some of us who will be great as retention specialists. And that's not just for trans folks, but that's for all folks. It's important to understand that trans people are needed in research, in development, in implementation, and also evaluation, in policy and data creation, interpretation, of course, facilitation, regurgitation, and in every single thing that involves data. So I'm happy to give the rest of my time back to Annalise. I think there's only like one more slide anyway.
Yeah. Well, and thank you, Tori, Evelyn, and Becca. I mean, I think some of the things I wanted to talk to you about was, you know, TRANSnetwork has been doing this work in the South specifically, and there's so many things each of you shared about that just had my brain popping around like, well, how does this work really look in the South? So for instance, you know, mentorship, you know, I think, Evelyn, you talked about healthcare providers taking things personally, right? That, you know, we can say that, but there's a certain way that happens in the South. I think, Becca, you talked about advocacy and paperwork issues. Like, how do these things play out in the South, and what do we need to keep in mind? I know we have people attending from all over the country, and I'm just really interested in how this work happens in the Deep South. Maybe we can start with you, Tori, because I know you've done so much of this work.
Yes. So repeat your question. I was reading.
Just, you know, like you're talking, your next slide is about mentorship and, you know, all the wonderful things you talked about engagement, paying trans people to do the work, not just like, you know, stealing from trans and non-binary networks, but actually resourcing people. What are the specific Deep South implications of doing that type of work?
So mentorship, which is on this slide, and then the next slide, which is internship, those are systems that were created a long time ago for people to help to get, and nepotism, they were created well before any of us were around in order to help folks get other folks in their positions. And I think that's really, really important for us to understand. It is not a fair expectation that every trans person has a master's degree. But it's also not a fair expectation that every person that works in public health has a master's degree. And so if we know statistically trans folks have lower education levels and less access to education and housing and employment, then we can use internships and mentorship programs to combine their lived experience along with on-the-job working experience, really to create kind of superstar I don't want to say sales force, but superstar staffs for the next generation and the next wave.
Thank you, Tori. And we've got several questions. So I'm going to give this next one to Evelyn. How would you refer to a patient who's opened up to you as a medical professional as identifying as trans? However, they have not clued their family in to their gender identity and expression, particularly when their family is present during the engagement. We've got like literally a minute left, so good luck with that. And then I'm going to give the next minute to Becca.
That's it's certainly a very sensitive situation. I think in the case you described, of course, there's probably a lot more details to any such scenario. But if it has been disclosed to you that the parents or family or whoever is present is unaware, I think that in that case, that's probably as good as getting explicit permission to not disclose their trans identity. They may not come out and say those words, but if they say, "Hi, I'm trans, and also this person who might be here in an appointment for me doesn't know that," then yeah, you don't want to be disclosing that to people who you are aware do not know that information yet. Sorry for a rushed answer. That's a complex one.
I think that's great. And folks, well, if we put up the last slide, you can see how to contact us. This question is for Becca. What are some additional advocacy steps providers can take in addition to the great ones we've shared to support trans and non-binary youth specifically?
Oh, absolutely. So very quickly, I think that we need to be more involved in schools. I think as mental health care providers, we can definitely partner with school counselors, partner and identify allies and conspirators within the school setting, both teachers, school counselors, but then also kind of taking a more macro approach. So identifying principals, folks who are, in upper realms within the school system. I know Annalise, for example, created here in Georgia, remind me of the name.
The Georgia Safe Schools Coalition.
Yes, so like here in Georgia, we have the Georgia Safe Schools Coalition as a way to help folks network and find one another. And so feel free to contact me. My email address will be up on the screen on the last slide. And we can also talk about ways to help you in wherever you are start to connect and find other people to work with. But I think the first thing that comes to my mind for you specifically is school.
Awesome. And I know there may be lots of other questions. Evelyn, can we go to the very last slide so you'll be able to see how to contact us? And I just wanted to thank each of you for sharing of your time, especially on, such an important day of Trans Day of Remembrance and Resilience. Tori, I know this is one of 4 webinars you're doing today. So, what I want to say is thank you. And this is labor that trans and non-binary people are doing when I think we who have privilege need to be really making sure that these resilient strategies don't need to be used. And Evelyn, I want to thank you for all of your work at the CDC and in TRANSnetwork as well. I think you have brought not only a research mind, but a personal perspective to the work. It's been an honor to work with both you and Tori. And Becca, I get to work with you all the time. So I feel honored and privileged to learn alongside you. To all the attendees, thank you for being with us here today. I want to give a shout out to our partners in Arkansas and North Carolina who aren't here with us today. Kate Stewart, well, they're here as attendees. Kate Stewart, Alex Marshall in Arkansas, and way more partners there. And then our partners in North Carolina, Tonya Petit, and lots more people that I can't mention. So thank you. Please consider taking 5 minutes today to make a post on social media, to contact your physician or mental health care provider and ask them to do something different in terms of taking the next step. and then takes the next 5 minutes to take a review and see about what you might need to do in terms of next steps in your paperwork. So have a wonderful day, and thank you for joining us.
Thank y'all.